In 1912, coronary thrombosis was so rare in a living patient that it barely existed as a clinical diagnosis. The electrocardiograph was just making it possible to identify blocked arteries at the bedside. But by 1968, heart disease had surged to become the undisputed leading cause of death across the industrialized world. For those suffering a myocardial infarction, a heart attack, arriving at a hospital alive offered bleak odds. You faced roughly a 1 in 3 chance of never leaving. The standard evidence-based treatment of the era was simply 6 weeks of strict bed rest, hoping the damaged tissue would survive the initial shock. Then the trend reversed. Between 1970 and 2022, age-adjusted mortality for ischemic heart disease in the United States plummeted by 81%. It is one of the largest sustained mortality declines ever documented for a major cause of human death. The common explanation credits this victory to modern medical invention.
But the chronology makes that impossible. Coronary mortality had already fallen by nearly a third before the first statin reached the market in 1987. It dropped before the widespread use of ACE inhibitors, before primary angioplasty, and before organized trials proved aspirin worked in emergency settings. Since the steepest part of the decline happened decades before the therapeutic revolution arrived, crediting our modern cardiology toolkit for the victory is historically inaccurate. To read this 81% drop, we look at a simple equation. Population mortality is event incidence multiplied by case fatality. Incidence is the macro-scale frequency of populations having heart attacks. Case fatality is the micro-scale likelihood of dying once an attack begins. If mortality falls while incidence stays flat, the gain came entirely from emergency rescue. If mortality falls while case fatality stays flat, the gain came from preventing the disease from happening at all. To understand what saved millions of lives, we have to isolate these two variables. We will start with incidence. It is tempting to credit the drop in total heart attacks to a sudden surge in individual willpower, people simply choosing to eat better and exercise. The data shows something much larger at work. In the 1960s, over 40% of American adults smoked. Heavy taxation, advertising restrictions, and aggressive smoke-free legislation systematically engineered a massive drop in population-wide tobacco exposure, directly cutting atherosclerotic risk across the entire country. The food supply shifted on a similar scale. In places like Finland, community programs aggressively replaced dairy fats with plant oils. After the economic transition in Poland in 1991, consumer subsidies for animal fats vanished, and cheap imported vegetable oils flooded the market. In both cases, national cholesterol levels and heart attack rates plummeted, without a single statin prescribed. Physicians integrated blood pressure medications into routine primary care, creating a systematic, daily reduction in vascular stress across tens of millions of adults. Policy, environmental engineering, and early chronic medications changed the underlying risk profile of entire nations. By the late 1990s, having fewer coronary events accounted for roughly 2/3 of the total drop in historical mortality. But prevention inevitably fails some people. That brings us to case fatality, the technological war to save the patient who is actively having a heart attack. The first major breakthrough required no drugs at all. In the early 1960s, hospitals introduced the coronary care unit. By continuously monitoring patients and standing by with defibrillators, doctors could instantly reverse the ventricular fibrillation that was killing patients in the first few hours. Hospital mortality dropped from 30% toward 15% almost immediately. The 1980s brought the pharmacological rescue revolution. Trials definitively proved that simply giving a patient aspirin, combined with clot-busting thrombolytic drugs, dramatically reduced acute biological damage to the heart muscle during an infarction. Physically opening the blocked artery with a balloon and stent, hospitals compressed treatment times and pushed case fatality down to an astonishing 4 to 7%. Through these interventions, emergency cardiology took a heart attack from a 30% death sentence to a survivable medical event. The healthcare system owns the rescue side of this equation. This animated model of U.S. data between 1980 and the year 2000 illustrates how these forces interact. We start with the actual observed heart disease deaths in 2000. If we remove the medical treatment gains, we add roughly 159,000 deaths. If we instead reverse the population risk factor improvements, we add about 149,000 deaths. The symmetry here is exact. The historical debate pitting medicine against lifestyle is a false dichotomy.
Postponing 500,000 deaths a year required the total, simultaneous synergy of both variables working together. Around 2011, the 100-year decline in coronary mortality abruptly leveled out in high-income nations. The momentum that defined the 20th century stopped. The most recent data reveals a disturbing trend. Among younger adults aged 18 to 54, in-hospital mortality for first-time acute infarctions, or STEMIs, is actually rising. We are losing our grip on the equation. The easy policy wins from tobacco control are largely exhausted. And in the United States, national control over blood pressure has deteriorated significantly, falling from nearly 54% in 2014 down to under 44% just 4 years later. Compounding the problem, severe obesity and type 2 diabetes have acted as massive epidemiological counterweights, actively subtracting from our cardiovascular gains for the last 30 years. The environment has shifted. We are currently losing ground because we are fighting a new cardiometabolic reality using a 20th century playbook that has already achieved its maximum yield. With in-hospital case fatality already compressed to 4 to 7%, squeezing a few more points of efficiency out of emergency rooms will yield diminishing returns for the population at large. The necessary shift means treating cumulative lifetime exposure, rather than waiting for patients to hit middle-aged risk thresholds. That requires tracking the actual buildup of atherogenic particles over decades, treating highly genetic risks like lipoprotein A early, and moving prevention upstream. We also finally have tools targeting the modern counterweight directly. The incoming wave of cardiometabolic treatments, like GLP-1 therapies, has proven capable of reducing major adverse events by actively reversing the metabolic damage driving the current stall. But the largest, most immediate opportunity requires no new molecules at all. It is closing the implementation gap. We have cheap, off-patent therapies that work perfectly, yet fewer than half of adults with hypertension are properly controlled, and millions miss out on standard lipid-lowering care. The next 100 years of survival will not be secured by a single miracle procedure waiting in a catheterization lab. It will be won by aggressively managing the entire equation of survival, every single day, across a patient's entire lifespan.